computer. And so, as I said, today we're going to be doing things a little different. I have a little class activity that we're going to do first. And how we're going to do this is our case study. And it talks about a patient. And for those that have, pre-read or whatever, it's fine. But after we do this, I'm going to let you fill in your answers. And at the end, we're going to come back and we'll see if your answers have changed. Okay, so you can just scribble along, but I'm not going to stop the presentation because we only have 50 minutes. So this is a patient that's addicted. This is a 45-year-old patient admitted, let's see, I'm gonna move this out the way, admitted to an acute care facility for medically supervised detox 8 hours ago. So you guys, if you've read your information, you know that detox is the part where they go in for medical treatment for withdrawal symptoms, and we wanna make sure that they're detoxed safely from the medication. We don't want them to have seizures or anything of that nature, or DTs, alcohol delirium. The patient was admitted because he was involved in a motor vehicle accident while driving under the influence of alcohol. And that's a common occurrence. That's a risk-taking behavior for a person that has alcohol abuse issues. Assessment findings reveal no physical injury, but a blood alcohol concentration of 200 grams per DL, which is equivalent to a 0.2%. Okay, and for the normal person that is not, I'll say a substance use disorder, but just your average drinker, 0.2% would be, they would not be able to stand or sit up correct in a chair without assistance, okay? But this guy, he has a long history of alcohol use. And so he's probably walking and talking normally because he built what we call tolerance. You know, it takes more and more because he's built up a resistance to alcohol. And so he has a 30-year history of alcohol abuse. So we could imagine he probably has some organ damage, particularly liver. He's been in rehabilitation facilities several times, but have always relapsed. And relapse is a normal part of addiction. You know, it's a chronic condition and relapse is a part. And usually when we have a patient that frequently relapses quite a bit, oftentimes instead of an outpatient program, we refer them to a long-term residential type program, whereas we're changing their lifestyle behaviors. And so this is a person that would go to places like maybe Odyssey House, or Bridge House, or Grace House, one of those long-term facilities. He lives alone and he's separated from his wife and his teenage children. And he hasn't seen them in a year. The patient has not been able to keep a job due to poor attendance, and he's been out of work for the past 6 months. That sounds like a depressing situation, huh? The patient also has additional DUIs under the influence of alcohol citations, and that's another risky behavior. So according to the DSM-5, what signs of substance dependence does the patient have? So you can look at those, and like I say, at the end, we're gonna go through and we'll answer these questions after we've gone through the content. When assessing the patient for alcohol withdrawal, which of the following observations should the nurse expect to make? And this is to select all that apply. And then, which of the following interventions is the highest priority for the patient at this time? And we look in terms of those. You have, this is a multiple choice. And then we have number 4, which of the following medications should the nurse anticipate administering to assist the patient with maintaining abstinence from alcohol? So this is a multiple choice there as well, okay? So we can move on to our next thing. That's gonna be our PowerPoint. So let's see if we can get to that. And go back to screen share. And I'm going to show you one thing with the SLO sheet, okay? So with our SLO sheet, you'll notice that number 1 is different from what's in Canvas, I'm going to go back and put this sheet in there. And it says compare processes involved in addiction and manifestations of substance use disorders. We're going to do that. And we got number 2 is we're going to look at the components of at least 2 substances. Our topics that we're concerned with for our course, or our exemplars are, we're looking at alcohol use and we're looking at opioid use disorders. And then we're going to go and we're going to look at care planning, including the pharmacological therapy for substance use disorders. And then we're going to discuss the characteristics of the chemically impaired healthcare worker and alternative to discipline programs. Okay, so I am going to go ahead and stop share this, and then we're going to go ahead and get to our PowerPoints. Okay, where is it? Okay, here we go. Okay, and so we start from the beginning. I hate this, that this is always over too far. Okay, so, but like, we'll get started. So we look at substance use disorders, and then we just go straight to number 1, which talked about compare the presence and the process involved in the addiction and the manifestations. And so we start with addiction, and we'll look at the definition of what addiction is. Okay, and this never works out. So addiction, we look at it as a psychological or physical need for a substance or process. An example would be gambling, and when we look at process addictions, and it's to the extent that the person becomes at risk for negative consequences in meeting the need. Okay, so when we say addiction, we think in terms of there are 2 types. You think of an umbrella. So we have substance and then we have process. Substance has to deal with the alcohol use, the heroin use, the opiates, the cocaine, and those. And then the other side of the umbrella, we're looking at the process addictions, which pretty much deals with compulsions. We look at things like gambling. You know, people have the issue with that. Shopping addictions, particularly at online shopping. We look at that. There's sex addictions, and we can go on and on with those, and those are called process addictions, okay? And so we will start by looking at, say, you know, we start with this addiction. Many people, you know, we start out with recreational use of a substance, right? And it's used to change our mood or our behavior. So we go from that point, and then it gets to the point where, like I say, it's recreational. And then we start to use maybe prescriptions drugs. You know, we start to use them more than is needed or is required, and this becomes dangerous, and it can lead to abuse. And we look at things like our narcotics, our sedatives, and our stimulants, and those type medications that might be prescribed for us or for others. And then we look at illegal drugs. And so we look at things like the cocaine, the heroin, marijuana. Well, marijuana is legal now, just plain marijuana, but when it's laced with hashish and things like that, those are considered illegal drugs. Then an individual may abuse any of these to the point of becoming addicted and unable to stop. And so when they get to this point, okay, forgive me, guys, but let me let these folks in, and then this blocks my slide. And so an individual may use any of these drugs to the point of becoming addicted, and then they're unable to stop. So we get to that standpoint, and then we get to what we talk about addiction and the types of behaviors that we look at. And we look at as compulsive behaviors, you know, where the drugs become the center of their world pretty much. So they're constantly drug seeking, and then the drugs seeking behavior is motivated by cravings. And then we get to the point where addiction is chronic and is relapsing. And we talked about it being a brain disease. And also we have cognitive impairment, and we identify these as the 4 C's of addiction. Okay, so let's move on to our next. And this is where we talked about the compulsive behaviors of addiction. We have gambling, we have overeating, shopping, and this is just to include some. This is not all. Okay, let me get all these folks in. Oh, they must have gotten out of class late. I'm sorry. I know this is as disruptive to you guys as it is to us, to me. So now let's move on and look at the assessment area of this situation. And we look at withdrawal syndrome. And that's pretty much related to any substance that we use. And we think in particular about alcohol when we think about the withdrawal syndrome. And we look at autonomic type behaviors when we think about the alcohol. What happens when a person goes to withdrawal syndrome? The brain gets overexcited. And when the brain gets overexcited, we end up with what? The blood pressure goes up. We have tachycardia. We have diaphoresis. We have irritability. We have all those things taking place. And that's withdrawal syndrome when it relates to alcohol. Okay? And then we have overdose that warrants medical attention. And this is where a lot of folks says, I'm not going to be a mental health nurse. But it gets to the point that when these people are in crisis, you're going to be the first ones that see them because they're going to the emergency department for treatment. And so the overdose that we're looking at, we think about the people that have had a heroin overdose. And when we look at that, what's the medication or what do we use to help these people in this crisis? Anybody want to take a shot?
Ativan, lorazepam, Haldol.
For heroin overdose, we're looking.
Okay, my bad.
Pardon me?
I thought you meant just like in general.
Well, that's alcohol, and yeah, you're correct with that one. But what about the heroin overdose? What do we usually use for respiratory depression?
Naloxone?
Yes, naloxone. We use naloxone. And and it's to the point now where as they give it to people that, librarians and people like that, because the libraries tend to be isolated areas where these folks tend to hang out and they, use heroin and things like that. And so if they go out and find the person, then they can inject him with the naloxone and it will instantly bring them back. So do we stop there?
No,
Why not?
because we need to monitor vital signs, make sure they don't.
Exactly. And then the naloxone tends to be short acting. So one dose might not be enough. It might bring it back, but then we still don't know. So you're correct. They need to be monitored. And sometimes they might need more naloxone, an additional dose after that. So that's correct. And so with alcohol overdose, what are we looking at? I'll give you a hint. I had talked about with the other classes, I talked about, the hazing and the fraternities and those behaviors that they do. And particularly at LSU back in, I think it was 2017, they had a situation where as they were hazing and this young man, he was succumbed to alcohol poisoning and he died. And as a result, his fraternity brothers end up going to court. And I think one was charged. I'm not sure if it was manslaughter or what it was. But guess what? The same thing happened last week at LSU again. Same scenario, same situation. And so as a result of that, that fraternity has lost their, I guess, whatever you want to call it on campus. They can't initiate, and they pretty much shut the house down. So they can't have their fraternity activities taking place. And then we look in terms of suicidal thoughts. Sometimes these people might decide, it's hopeless, it's helpless. And so we always assess everybody for suicidal thoughts. And then we look at other self-destructive behaviors, such as driving under the influence and things of that nature, getting into physical fights, altercations, and those examples when they are under the influence. And then, of course, we want to notify the patient and their families, assess what their knowledge is of resources that are available in the community. We look in terms of knowledge about maybe their support groups like AA that they might not know about, or Narcotics Anonymous. And then there's residential treatment programs and outpatient programs. And then there are detox programs, but detox is not considered a part of treatment. Detox is we are safely getting this patient through withdrawal symptoms. And once they've completed detox, then we go to the point and we ask them in terms of, are they ready to go into a treatment program for their drug use? And we go from there. But we evaluate for physical complications of substance use disorder. When we're looking at long-term substance use disorders or abuse, we have some physical symptoms, like I say, medical. We have liver disease that can be a factor, fatty liver, cirrhosis. We're just looking at not just alcohol, but we're looking at substances, period. We have hepatitis, HIV. All those things can be a factor. But with the alcohol, can have coronary artery disease as well. And so there are a lot of health implications that take place with this. Okay, let's move to our next slide. And here we look at some terminologies, say nurses need to know. And the ones that I've had the little asterisks by, they call those addiction terminology. So we know what intoxication is. We look in terms of alcohol abuse, and intoxication as a national standard for us is when that person is at 0.08%. And usually when that's what they do with the field sobriety test that they do on the weekends, and you see the police, assessing people. And with that, but they rounded it off to 0.1. And that is the standard for the whole, well, most states, I'll say, in the US. And when a person reaches this, they usually have slurred speech and they have dysarthria. Well, that's the same. Or they have ataxia, their gait is unsteady. So we have those things taking place. And then they usually have them to do the sobriety test. Tolerance. You guys familiar with tolerance? Okay, an example. I used to go out and have fun with my friends, and a couple of drinks would just kind of make me relax, and I would just be comfortable and just really feeling good. But now I've gotten to the point where it takes 5 or 6 drinks for me to get to that same place where I used to with 2 drinks. So you're building tolerance toward alcohol. You're able to take more and more and more in. And then we talk about withdrawal syndrome. This is when you stop drinking, a person that has become a chronic user of alcohol, and then you start to have withdrawal symptoms. This is where a person, you see them maybe putting a little alcohol in their coffee in the morning. They're taking the edge off because they're having the tremors of their hands, or their blood pressure is going up, or the diaphoresis, and those things are taking place. That's called alcohol withdrawal syndrome. And then we have polysubstance abuse, and that's, as it says, poly, where persons are using more than one drug. This person might be using cocaine to hype himself up, and then he might be using heroin to bring himself down, or he might be using alcohol. It's more than one drug. Commonly with our patients that might have issues with depression, they might have an issue with alcohol abuse. And then the schizophrenics tend to kind of like marijuana for some reason. And they also will use alcohol. And then we look at co-occurring disorders. Co-occurring means that you have a substance use disorder, as well as you have a psychiatric illness that might be taking place. Like I said, the depression with alcohol abuse. And the units that we go to, we call dual diagnosis, and that their main focus is on the substance abuse. They work with the patients from that standpoint. And then we have medical comorbidities, which we talked about earlier, the liver disease and coronary artery disease and things like that. Then we look at blackouts. What are they?
No memory of the time that they inebriated?
Mm-hmm. They've done these activities and they seem to be alert and involved, but the next day you ask them about it and they don't recall it. So that's called having a blackout. And then we look at codependency, and that's where you usually have a family member or your loved one that's involved with your dependency. We call what they do as enabling behaviors. And you might be just totally blasted from yesterday, and it's to the point where you can't get up and go to work, and so your spouse will call in and say that you're ill or things of that nature. And they say people that are codependent, they tend to have low self-esteem issues as well. Then we look at delirium tremens or alcohol delirium, and this is an emergency. When this takes place, we're looking at the patient has gone beyond the withdrawal syndrome, and now they're starting to have perceptual disturbances and maybe some distorted reality. So this is where we kind of start to see them having the visual hallucinations, not the auditory, but the visual. And then they have other issues taking place in terms of delusional type thinking or behaviors. And so those, when it gets to that point, usually seizures are involved. And this is when it becomes a real emergency. So those people need to be treated with medications. And sometimes they end up in ICU. So it's very serious. And we encourage people, do not try and withdraw from alcohol alone at home, but you need to come into some type of treatment program or have medical supervision. Then we're looking at Korsakoff psychosis. With this has to deal with the body's depletion of B vitamins, particularly thiamine, B1. And this is a result of the malnutrition that usually people, when they're abusing substances, they tend to have. And so they're depleted of their B vitamins. And as a result, with Korsakoff psychosis, they have issues where with recent memory, and they have difficulty trying to learn new things. And it's going to be some confusion as well. And then there's another part that we call Wernicke's that's a part of it. It's Wernicke's Korsakoff psychosis. And with Wernicke's encephalopathy, we see abnormal eye movements. And again, that is also related to the depletion of thiamine. Also, their gait is unsteady, and they too have some issues with confusion. But with the Korsakoff psychosis, we have another factor we call confabulation. And I think Dr. Hoppy probably talked about that in one of her lectures on cognition. So with the Korsakoffs, like I say, they can't learn new things, but then they have gaps in their memory. And so they fill in the blank with things that, are untrue, and those are confabulations. And then we have the physical dependency, psychological dependency, abstinence, and sobriety. Okay, so those are some terms that you need to be familiar with. So let's move on. And so, like I said earlier, our goal is to prevent life-threatening complications. And life-threatening complications tend to be those with the seizure disorders, seizure behavior, and the delirium tremens. And treatment, like it says here, is substance specific. So the treatment for alcohol withdrawal disorder is different from what we're going to use for heroin or for the others. So they all tend to be different. And drug overdoses, like I said, often seen in the emergency room. And these are the common ones that's listed here. So we're at alcohol, and we've kind of talked about that quite a bit. So, and it's one of the most commonly abused substances in the U.S., and it's more acceptable when we think of, a substance use disorder habit as opposed to the illegal drugs. People are more tolerant of alcohol because we use alcohol in so many settings. When we're at the ball games or football or weddings or you name it, alcohol is always there, and people engage and they're encouraging you to do more. So and it's also easily accessible. So our estimates is I think this has changed. Upwards of 19 million or so adults, have an issue with alcohol use. And then we look at our underage drinkers, and we're looking at 9.7 million underage drinkers in our country. And so you think in terms of the alcohol that's at home, so they have access to the parents' liquor cabinet. And it's going to be the same. You look at the abuse of benzodiazepines. A lot of times they have the medications from the family members, particularly opiates, the cancers, to relieve the pain. So they have access to those drugs. And this is what often happens with addiction in terms of that. So alcohol, some clinical manifestations. We're looking at severe liver damage, and we talked about the fatty liver. We've talked about cirrhosis with the esophageal varices and those type things. And so we have those as it relates to the liver, hepatitis, and all those we've mentioned earlier. We kind of touched on the malnutrition complications of chronic alcohol abuse, and that's the Wernicke's and the Casa and the confabulations. But we know that alcohol becomes the food of choice when the person has chronic abuse. And so, like we say, they're often malnourished because they drink as opposed to eating what at the amounts what they should. And it also disrupts their sleep patterns. We talked about tolerance, and then we've talked about the severe manifestations that we want people to be medically supervised so that they can avoid the seizures and the convulsions. Convulsions used to be called grand mal seizures, so now they call them convulsions. And then we have the delirium tremens that include the hallucinations, and they're mostly tactile and auditory, and delusions that might take place. So when we move to collaboration, we're looking at the tests that we use, the breathalyzers. They even have these in the emergency department when their patients come in and they suspect alcohol intoxication. So they do the breathalyzer to assess and see where their levels are. And know that when a person is under the influence of alcohol, they're incompetent to sign legal documents. So we have to monitor them until their alcohol level gets to below 0.8%. And then we know that they are no longer intoxicated. So when we talked about the blood alcohol levels, like I said, the average person, we respond different from a person that has tolerance. When we look at the 0.1%, 0.1%, like I said, those people, they have unsteady gait, and their coordination is off, and then that's what they use with that one. When they're at 0.2 to 0.25%, they're unable to stand or sit upright without assistance. When we get beyond that to 3 and 4, we're looking at serious complications where they could very easily be victims of alcohol poisoning, which is drinking many drinks in a short period of time, and their blood alcohol level tends to keep going up even after they have stopped drinking. You know, instead of it going down, it goes up because of the saturation of alcohol in their systems. And so when we get to that point, alcohol poisoning, we're looking at coma, depressed respirations, and it could lead to death. And we're also looking at, in terms of the person that has tolerance or the chronic abuse of alcohol, they might be walking normally with the blood alcohol of 0.3% because they build tolerance to it. So we look from that standpoint. And then these treatments they have here with withdrawal syndrome, pretty much this is kind of the old stuff that they used to do. So basically what they use now is the Clinical Institute of Withdrawal Assessment for an Alcohol Scale. And with this scale, what they do is they have, and this is standard protocol in most facilities, they have this chart that has the scale, and if the patient shows certain symptoms, maybe a pulse greater than whatever, then they are, I think they have to have a combination of the different symptoms, and they get medication according to what those symptoms or that number is. And so that's how they kind of take care of, deal with that. In assessment, we're looking at past alcohol abuse or substance use. We want to know the frequency, last time they used, and how much they use. And it's very important when a person comes into the emergency room, that one of the first questions we want to ask is, what substances have you used? Because we might be thinking it's alcohol, but then we look and then they can give us an idea of other drugs. Well, I had alcohol, and then I had some cocaine. So we know what we're treating this patient for. Because like I say, each drug protocol or each substance protocol is different. So we can look at that. And then we look at the medical history. Are there chronic abusers? If they are, we have some medical complications we're looking at. And then we have these screening tools that we use as well. Use it in mask. And then they have the CAGE questionnaire. So with the CAGE questionnaire, they might ask what kinds of problems that substance abuse has caused for you with your family and friends or job in terms of your health and finances. And with the mask, we might ask, have you ever neglected your obligations, your family or your work, for 2 or more days in a row because of your drinking? Or they'll ask, have you ever had delirium tremens? That's severe shaking or hearing voices or seeing things that were not there after heavy drinking episodes. And then we have the dash, drug abuse. This one we'll ask them, have you had blackouts or flashbacks as a result of drug use? And then number 2, we'll ask, do you ever feel bad about your drug use? And then we'll ask, have you had medical problems as a result of your drug use? Like memory loss, hepatitis, convulsions, and bleeding, and things of that nature. So those are some scales or some assessment tools that are used in substance abuse. Okay. So I talked about the protocol with alcohol withdrawal or alcohol. So these are the protocols, and these are usually standard in each facility. They usually have the standard orders in terms of the early signs. Typically within 6 to 8 hours after, you'll start to see some withdrawal symptoms, and they talk about them peaking around the second day, and usually by day 4 or 5, they're pretty much sometimes in the clear. But we always ask a person, because each time that they go through withdrawal, it might be different. Last time they might have had just excessive nausea and vomiting, and it took them a longer period of time. Or this time it was relatively not so severe. And so we have to kind of assess and we ask, but we don't expect the same thing. Also, in terms of treatment, sometimes our patients will come in and we see them as frequent flyers, and it gets to the point where we say, oh, here they come again. I encourage you as nurses, never be judgmental, because this might be their 10th time coming in, and this might be the one time that they are actually successful. So we always instill hope in our patients. And so, like I said, these are the symptoms of alcohol withdrawal versus alcohol delirium. And you see the last little asterisk on alcohol withdrawal, it says in rare cases, grand mal seizures or the convulsions and the intermittent hallucinations. What we do to prevent that is our seizure protocol. In seizure protocols, we don't think about the bite that you should try and force into people's mouths, but you think in terms of medication. They try and ward off those symptoms by treating the patients with benzodiazepine, or anticonvulsant medications. And so those are our seizure precautions that we use. And so hopefully we use these and we taper off those withdrawal symptoms, and we can avoid alcohol delirium. But sometimes these people might be at home, or they might be somewhere else and they're withdrawing, and it's going to be a medical emergency, and they could possibly die from it. In fact, they say 20% of people that do go into alcohol delirium they do end up dying. And so these are some of the symptoms we look at. Autonomic hyperactivity, we want to know what that is. Those are the vital signs and the things we talked about. And sensual and perceptual disturbances or the delusions or the hallucinations. I'm sorry, I can't talk. And then we can get to loss of consciousness, that body temperature is going to elevate, and you're going to have some agitated behaviors. Like I say, they will probably end up in ICU. I haven't asked any questions thus far, because I am just chugging right along. Okay, so like I said, we want them to withdraw safely. And so these are the standard protocols: vital signs, Q 15 minutes until stable. Then after that, they change to maybe every 4 to 8 hours. And we're going to provide them with a quiet room free of environmental stimuli. Why do we do that? We might have the lighting low. We want to avoid the occurrence of seizures. Remember, that brain is overactive, is excited now. And so we want to give them a calm environment so that brain can begin to kind of calm itself. We use simple, concrete language and directions. These people are feeling bad. They don't want to hear a whole lot of information about you trying to teach them, this is not the time for it. We want them just to safely detox. So we use simple language. If they're confused, we're going to orientate them. If they're having delusions or hallucinations, we want to assure them that they're safe and we're there to take care of them. And of course, we're going to do those seizure precautions, which tend to be that medication that we use to avoid the seizure complications. So here, this is continuations. We want to monitor their intake and their output. You know, there's a lot of nausea and vomiting that will probably be taking place. We want to make sure they're hydrated, and we'll give them medications to relieve the nausea and help with the vomiting. And if they're hallucinating, like I said earlier, we want to assure them that they're safe and that you don't see what they're seeing. Maintain safety precautions with them, and administer the medications ordered according to that CIWA scale that I talked about earlier. Use of restraints. That's always the last measure. We try and avoid the use of restraints, but sometimes for patient safety, as a last resort, restraints might need to be used. So we look at the medications that we often use. And we have naltrexone, and the brand names are called Riva and Vivitrol. Riva is the pill form, and what they do is they eliminate the cravings of alcohol. But this drug is also used with opiate withdrawal as well. And so between the two of these, the one drug, the Riva is the pill form. So what they do, or it might be a little, what they call a strip. And once you put that strip on the patient's tongue, it evaporates. When you give them the pill form, they used to put it in the cheek, like I say, in the bronchial cavity, or they might give it sublingually under the tongue. And this is how this is taken. Vivitrol is an injectable, and it's more long acting. In fact, we had a patient that was being discharged from our dual diagnosis unit. She was trying to make sure, from the psych unit, but she was trying to make sure, I need to get my shot of Vivitrol before I leave, because she had a substance abuse or an alcohol abuse history as well. And so we also look at Camprol. That helps with abstaining from alcohol as well. It blocks the craving. Look at Topamax. What is that? That's an anticonvulsant, but it works to decrease the cravings for alcohol as well. And then we have disulfiram, which is antabuse. And antabuse and naltrexone, those are the most common two that you'll probably see, are the most researched and used ones. And so with disulfiram, we call that a deterrent. It discourages the person from drinking alcohol because of the side effects. It makes you violently ill, and it has nausea and vomiting and those type, and flush, face and those type things taking place if you use disulfiram. So a patient would typically take that medication each morning, and you know that you've taken this medication and you do not want to become ill. And so that would be your deterrent to not drink alcohol. As the nurse, it is our responsibility when a patient is going to start taking antabuse, is we have to do patient education. Make sure that patient is aware of reading labels to make sure that alcohol content is not in whatever they're taking. We think in terms of the cough medications, or particularly those, they have alcohol included in them, and they can become ill from that. You think about the aftershave lotion that they might use, and just make them aware to read the labels and make sure that there's no alcohol in the products. And so that's patient teaching for us. Anything on alcohol? You guys are clear? Okay, so let's look at the opiates. And so you'll notice I have on the intoxication effect, those little asterisks I have by the pinpoint pupils, the decreased respirations, and coma. When you find a patient in those situations, you could almost be assured that they have an overdose. This is where we pull out the naloxone. But these are some of the other symptoms that take place. Now, let's talk about heroin. In particular, when that patient, they inject the heroin or however they take it, what happens is it first gives them a little, like say, a brief little kick that lasts for maybe a minute. Then after that, they get the effects that they want, the euphoria. And then you see them kind of just at, you know, in that point, and the kind of laid back situations that they usually associate with the abuse. Withdrawal effects of opiates is listed here as well. Now, the thing with this, alcohol, they can die with the withdrawal symptoms, but opiates, it's not usually a life and death situation. You know, they might, with heroin I'm talking about, these are the withdrawals. So they think they might feel like they have a real bad flu, or the cramps, the muscle aches might be so unbearable. And like I said, the nausea, the vomiting, and the diarrhea will be to the point that they just find it unbearable and they just go ahead and use just to relieve those symptoms. But usually if the person can sustain usually 2 or 3 days, then after that, it gets better. So by day 5, they're usually feeling much better and they're able to go on. So oftentimes they use different other medications. We've talked about naloxone already in terms of the opiate overdose. So these are our, you know, our little standard protocols. Withdrawal symptoms usually begin in 6 to 8 hours past their last dose. So I know I used to take students to Odyssey House, and we had the detox program there, and the patients would tell the students, you know, get all the information to talk to me today, because tomorrow I'm not going to be able to talk to anybody. And sure enough, the next day we come back, they would have the blankets over their head and they would just be miserable, you know, with those symptoms. And oftentimes some people would say, I just can't take it, I have to leave. So they would sign themselves out, but they had their peers there that would, you know, peer pressure. Come on, let's just take it 1 hour at a time, or we can get through this. And that would be, you know, some of the things that they would try and use to coax that patient to stay. Oh Lord. Excuse my house phone, I can't turn it off. And so we look at opiate withdrawal therapy, and basically with that, we're looking at rest. We give them adequate nutrition, and we give them some support. Sometimes they might give them something to kind of help with the symptoms of the nausea and vomiting, or something to kind of help with the muscle cramps or the aches, and that's basically it. You know, and like I said, the naloxone, they use that for short acting. And then we have what we call the methadone tapers, and methadone has been around for a very long time. And so with the methadone taper, the patients used to go to the methadone clinic. This is, excuse me, y'all. This is so annoying. I hate spam calls. I really hate them. And so, I thought she was finished. With the methadone taper, what we do is the patient usually go to the clinic, he gets a certain amount of methadone. And the purpose of methadone is a synthetic form of heroin. And basically what its difference is that the patient is able to be productive and they're able to function, and they do not get that high that they would normally get from the heroin. So that's the difference. And what the goal is to taper them off. But if they plan to go out of town or someplace like that, they have to locate the methadone clinic and take their prescription with them. Let's see, I cannot never pronounce this word. Buprenorphine. This is a medication that is often given by the courts, and this is it's a pill form. And this is, like I say, sublingual, and the patient use this as well to taper and to get off of off of heroin. And then we have clonidine. They also use that for symptom relief, and that's an antihypertensive medication. All right. So evaluation. What we hope is that our patients will detox safely without complications. We hope they will be able to acknowledge that they have a substance abuse issue, and that they will go ahead into treatment programs and things of that, attend their daily group meetings, whether it's AA meetings or whatever, and remain substance free. And that's our goal with those patients. But we know that relapse is a part of the recovery process, because it's a chronic disease. just like diabetes are those, and you just have to treat the symptoms and you have to manage it. Okay, so now we're moving on to the impaired healthcare professional, the nurse, the students. And this is the definition of an impaired healthcare professional, is the inability to practice according to accepted standards as a result of substance use, abuse, or dependency. And so from there, you guys did state board testing, you did your drug screens and things of that nature. So we have baseline information. So if you become have these issues, then you will have to be monitored, or you will go before the State Board of Nursing. So these are some symptoms that we often see, or some warning signs with an impaired nurse. And these are the risky behaviors or situations. You know, there's easy access to prescription drugs. So in these situations, you might have a person that has a substance use issue. She's the nurse, and she's going to probably volunteer to go give medications to your patient, and the patients are going to complain and say, you know, I didn't get any relief from the medication, because she has probably given them part of the dose. She's given them part and she's taken the other part for herself. You know, so we look for those situations. We might have inaccurate narcotic counts, or, you know, drugs are frequently missing when they are given the medications. I mean, yeah, when they're administering drugs. So when you go to do your drug count, you're looking at, she'll probably volunteer and says, okay, I'll count. And then you just write the numbers down. And then she'll probably come across an ampule or something there. And she says, oh, the top just fell off of this for no reason. It makes no sense. The top fell off because she took the medication out and she refilled it with water. And that's the reason why she want to count herself, so that she can say this top just fell off. Well, I'm so glad you're here. We can go ahead and you can sign off, and we're wasting this drug, whereas they're actually wasting water. So there are different tricks and things that these people might do. So we want to observe them for their abrupt mood swings, always in the bathroom, maybe the smell of alcohol on their breath, wearing long sleeves in hot weather, frequent absenteeisms, and then you might notice some withdrawal symptoms. So those are the things that we look for. So what do we do in those situations? Do we say, girl, go get some coffee, I'll take care of the situation for you? No, we do not. Or I'll handle it. No, you report those behaviors to your supervisor. It is the supervisor's responsibility to manage that particular employee. We're thinking in terms of the patient's safety. You know, if you decide to cover, then you're putting the patients at risk, and you're supposed to be that advocate. And then we look in terms of that person's future, in terms of them not getting treatment. They can lose their job, you know, but, and it used to be a form of punishment when a nurse came across as having a substance abuse or a mental health issue. You know, that was just it. But now, with new standards set by the ANA, you know, and they have these proposals and these things set up such that a person that does, if they declare that they have an issue, then they will supervise them and let them go into treatment programs. And once they come out of the treatment programs, then they have the alternative to discipline programs, whereas they're monitored by the state board, and they have peer supervisors who've also gone through maybe substance abuse issues as well. And, you know, you gradually return back to nursing. Of course, you're not going to be handling narcotics for a long period of time until they can see that you're able to safely maintain sobriety and follow the guidelines of the profession. So let's see, what's our next? Okay, so this slide we've talked about these before. So that's I don't know how that slide ended up down there, but oh, I see, I didn't go down. All right, so we talked about these, and then this is our alternative to discipline programs that are in place. And they say that up to 20% of our practicing nurses have addiction to alcohol or substances. And we know that you guys as students are vulnerable as well because of the stress that you're going through in terms of trying to pursue your degrees. So we do clear documentation, like I say, we intervene, and this is the responsibility of the nurse managers to manage this. And what we can do is we can document the behaviors and things that we see. And if you must report to the state board, then it's strictly objective, not what you think, but what actually happened and what actually occurred. And this is our link to our nurse recovery program for our State Board of Nursing. Okay, so we covered that. Let's go back to our case study, and we'll do that real quick because we do not have a lot of time. So I think it's here. Okay, so we'll go from the, come on, where's my little thing? We'll go from the beginning here. We talked about the scenario. So according to the DSM-5, what signs of substance dependency does this patient have? Anybody?
Tolerance to alcohol, unable to keep a job, multiple DUIs.
Okay, very good. Anybody else have anything else different? When assessing the patient for alcohol withdrawal, which of the following observations should the nurse expect to make? Select all that apply. I'll speed it up for you. Okay, bradycardia, no, that's the exact opposite. Remember, the brain gets excited and they go into autonomic symptoms, and so it's going to be tachycardia. Fine tremors of both hands, yes, that's possible. Hypotension, no, it's the exact opposite. Their blood pressures are going to go up, so they're going to have hypertension. Vomiting is a complication of withdrawal or symptom, yes, and also restlessness. So those are your answers, okay? And then we'll move on to number 3. Which of the following intervention is the highest priority for the patient at this time? What's the highest priority?
Implement seizure precautions.
Exactly, that is correct. Okay, because group participation, the patient feels bad, they're not going to want to participate in groups at that time. Orientate to time and place as needed. We'll do that if they get to that point, offer fluids and nourishment, but we look at the highest priority, and the highest priority is to implement seizure precautions. Okay, and our last one is number 4. Which of the following medications should the nurse anticipate administering to the patient with maintaining abstinence from alcohol? So when we look at that, we want to, which one?
C.
C, disulfiram. That is correct, right. Librium A is often used when we are doing withdrawal behaviors. That might be a medication to help them with withdrawal symptoms. Zyban, that's usually used for what? Smoking cessation. And then Tegretol, that's a anticonvulsant medication that we would use as a part of maybe with the withdrawal process to prevent DTs. But the medication we would use here, maintaining abstinence, we're using the alcohol deterrent, which is Antabuse. Okay? Any questions? Okay, so this concludes this class, and I will stop the recording.